Okay, I mentioned in the last chapter when we were talking about safety that we would talk a little bit more about preventing falls. Falls is a big safety hazard for our residents. We've mentioned one of the reasons that this happens is because they are, as they get older, their muscles tend to weaken, their sense of balance changes, their hearing and vision changes. It's one of the most common accidents we see in nursing homes. So a history of falls increases every time there's been a fall. So if you have a resident that has fallen in the past, they're automatically considered a high risk fall patient. Some causes of falls are poor lighting, cluttered floors, throw rugs, slippery floors in bathrooms. And that's something we have to be very careful with. When we give our residents showers, those floors get super, super slippery for us and for the resident. And as far as throw rugs, you won't even find those in a nursing home because there's such a huge trip hazard with walkers and when people are trying to get around. Falls frequently occur between 6 and 9 in the evening, and part of that may be just because they're tired as the day has worn on. And it's also very common during shift changes because the off-going shift and the ongoing shift are talking to each other and not really paying attention to the residents at that time. So things that can increase a person's risk for falls: alcohol, balance problems, confusion, or dementia. And we've mentioned that dementia is a loss of cognitive function, medications, elimination needs, muscle weakness, poor fitting shoes. All of that can play a role into increasing a person's risk for their falls, especially as they're getting older. So there are different fall prevention programs. Bed rails is one of them, but nowadays it used to be we could put all four rails up, and then they decided that four rails was a restraint, two rails were considered a positioning device. Now the state has determined that bed rails are a restraint. So if a patient does want the two upper bed rails up for positioning device, they have to sign for it. They have to sign a release that they can have them up and that they are not considering it to be a restraint for them. The bed should always be lowered in the lowest position when you're done giving care. I mean, obviously we bring it up for good body mechanics, but when we're done, if we don't lower it back down and our patient climbs out of bed or falls out of bed, that could be a huge safety issue. Handrails or grab bars should be in hallways and showers. And shower chairs can be used. Those floor is really slippery. So if you have a patient who's not really steady on their feet or they are a fall risk, we would give them a shower in a shower chair. As far as wheel locks go, we've mentioned that it is okay to lock your wheels of a wheelchair when you are transferring a patient into the wheelchair or transferring them from the wheelchair into another area. But once they're in that wheelchair, we cannot keep those wheels locked, otherwise it's going to be considered a restraint. Now, bed locks we would keep locked. So the bed itself, we do want to lock the wheels on the beds. So when we're putting a patient in and out of bed, that bed doesn't go rolling away. We always want to make sure the person has non-skid footwear on before getting them up, and eyeglasses if they use them, and hearing aids as needed. Other things we do for fall prevention programs is we make sure our patient knows how to use their call light. So it's important that it's always positioned in easy reach for them and that they know how to use it and that they're not afraid to use it, that we don't look at that as something that they're bugging us. Because a lot of times residents don't want to put their call light on because they know how busy we are and they're afraid they're bothering us. Tab alarms, this is an example of a tab alarm. So it clips onto the resident's clothing, and then this part is usually a magnet. And so if the resident starts to get out of bed without help, then it's going to pull the magnet off of this and it's going to start alarming. And it used to be the alarms made these horrible screeching noises. Some of them nowadays, they actually play music. So you might hear music start playing. But if you're hearing a tab alarm go off, it means a patient who's considered a really high fall risk is trying to climb out of their bed or their wheelchair. And you need to go check on it, whether it's your patient or not. Hourly rounding is something that we can do as a fall prevention program. And I know that sounds like it might increase your workload, but they have found that hourly rounding actually decreases the amount of, it actually can decrease your time over the day. And what hourly rounding is every hour you go by and you check on your residents and you just ask them, are you having any pain? Do you need to be repositioned? Do you need to go potty? We call it the 3 Ps of hourly rounding: pain, potty, position. And so if you do that every hour and then you say, okay, and I'll be back in about an hour to check on you, they have found that people are incontinent less. There's less falls, so there's a lot less paperwork and a lot less work when somebody doesn't, than when they fall. It's much less paperwork if you can catch them and prevent this. So less incontinence I mentioned, which means better skin care. And then they have found that just patient satisfaction goes up and people use their call lights less. So though it sounds like it's going to take a lot of time on your part, they have found in the long run it generally will reduce your workload. Answering call lights promptly. The other thing you'll notice is it pads next to the floor of the bed. So what they do is they put the bed down in the lowest position for our fall risk patients, and then they get these gym pads, and they can put the gym pads all the way around the bed, so that way it can, if they do end up falling out of bed, they're going to land on a soft landing. And then anytime you go in and check on your resident, anytime before you leave, just do a safety check of that room. Is the bed in low position? Is the call light in reach? The things they normally use, are they in easy reach for them? And is there anything else that looks out of place? So these are some examples of bed rails. So the full-length rail, obviously, that's going to be considered a restraint. The 4 is considered a restraint. Well, as I mentioned, all of them now are considered a restraint. But you're going to find these small ones still being used, and the residents will actually sign a release for them to be able to keep those on their bed, because it really helps them. It gives them something to hang on to when they're rolling on their side to get cleaned up. If they're trying to help lift themselves up in bed or, grab something, it just gives them a little bit of a handhold to hang on to. And so we have found that many of the residents really prefer to have them on the beds. And so a lot of them do sign the releases, but you're going to find some beds that have no rails anymore. Another thing that we do to keep our residents from falling is when they're a fall risk, we should be using a transfer belt or a gait belt. So gait belts, G-A-I-T, gait. We've talked about these before when we talked about the moving patients, body mechanics and moving patients, but belts can actually help you support a person who is unsteady. So you do not ever want to position the buckle in the front. It should be off center in the back, not over the spine. It should be snug, not so tight that it's cutting off their circulation, obviously, or where it's really making them feel uncomfortable. You should be able to get a few fingers under it. But if it's loose, the minute they stand up and their body kind of sucks in as they stand up, that gait belt is going to become too loose. It should always be over clothing, and we don't allow excess strap to dangle. You want to tuck that in. And if the person has tubes or dressings that the belt might interfere with, or they've had a surgery to their stomach, feeding tubes, anything like that, you want to check with the nurse first. Now, one thing I want to mention is you see here that this person's kind of holding it from the top. You always want to come underneath the gait belt. You always want to hold it underneath, because if I'm holding it from the top like this in this position and the person falls, it's just going to slide right out of my hand. If I've got it this way underneath the belt and they start to fall, I can take the belt and kind of help guide them down. I thought this was cute. It says, the look I give my patient when they're trying to get out of bed. It can be a wild look. Your patients will frequently try to get out of bed. But when a person is falling, we shouldn't be trying to stop the fall. And you'll see many CNAs do this. The resident starts to fall, and it's a lot of work when someone falls. You have to stay with them. You have to wait till the nurse and the physical therapist comes and checks them out. We have to notify the doctor. An incident report has to be filled out. The family has to be notified. The patient has to be checked and vital signs done every 15 minutes for a while, and then every 30 minutes, and then every hour. It's a lot of work when a patient falls, and the CNAs don't want that to happen. So when their resident starts to fall, they try to help. They just try to hang on to him and support all that weight, and that's how a lot of times they get back injuries. So bring the person close to you and help ease that person to the floor. So I know when we've talked about infection control, we've said, our uniform's considered dirty, but when a person's starting to fall, you can take them by the gait belt, bring them up against you, and just kind of let them slide down your leg and stuff so they can be eased to the floor so they're not going to break their hip or hit their head. Try to protect the head as much as possible. And again, stay with them, but don't let them get up. Don't try to move them until that nurse and or physical therapist comes and evaluates them. And then, of course, we're going to have to document really well what happened. Okay. As far as using lifts go, we did talk about this when we talked about moving our patients with the body mechanics lecture. But when you're using lifts, when patients are dead weight patients and we have to use these lifts, be safe, okay? It's always going to be safer to have a second person with you to use these lifts correctly, because it still takes some maneuvering and they're still really heavy. So you want to really keep that in mind. Make sure you're following the manufacturer's guidelines on how to use it. Make sure you're using the right size lift, that it's the right weight capacity, that you have the right size sling, and then always try to have a second person with you on these Hoyer lifts. So in conclusion, get help when you need it. Use gait belts when patients are a fall risk. Learn how to use the lifts correctly and safely. Get help when we're moving our patients up in bed. Protect ourselves and try to protect our patients as much as we can.